So our next speaker is going to be Raja Pillai. And he is a neurologist. Dr. Raja Pillai is a neurologist trained in neurodevelopmental disabilities. He is currently completing advanced training in psychiatry at the Kennedy Krieger Institute at Johns Hopkins. His clinical and research interests include improving mental health in patients with neurologic conditions.
Thank you very much. So I did my training at Boston Children's. Many of you are very familiar with Boston Children's. In particular, some of you may know personally Sid Srivastava and Zoe Frazier. So thank you to all of you who have seen them. I have not met many of you personally, although it's a possibility if any of you have had to be inpatients, I might have seen you there. But my work is going to be exploring some of really kind of looking through their work and trying to glean more information. You've seen a lot of brilliant talks this afternoon with really high-level concepts that can blow your mind as to what's possible. Let me assure you, I will not be doing that. So here is the title of the presentation, and here are my disclosures in case you need any proof that this is not a high-concept presentation. Someday I'll have real disclosures, but not yet. And so basically I'll go through, I'll do a very brief introduction. I don't think we really need an introduction at this point, but I really want to focus on three aspects. One, the neuropsychological profile, by which I really mean cognitive functioning and IQ, and then looking at different mental health problems that can come up in Kleefstra syndrome, as well as what we are currently doing and how helpful it really is. And so really going to just zip through this introduction. First of all, this is our clinic at 2 Brookline Place, and we have seen over 125 patients with Kleefstra syndrome at this clinic. Specifically, we've seen 126 patients with Kleefstra syndrome at this clinic. And so, but that number is going to keep going up. In fact, I think actually Dr. Sid just saw someone new today. So that's very exciting. You may be familiar with this. I think this was presented last year, but Zoe Frazier and our group have put out a kind of a retrospective on how different genotypes, so whether we're talking about a point mutation or a deletion, can result in different manifestations. And just to go through it quickly, here are, we do see developmental differences with patients who have deletions tending to take more time for development, and also when we go to more systemic and neurologic manifestations, we do tend to see some more manifestations such as epilepsy, microcephaly, that sort of thing, with deletions more so than mutations. And then here are some of the systemic issues, some of which you have heard about today. And so one thing I was interested in, so during my residency, I wanted to at some of the developmental differences in a bit more detail, and specifically looking at some of the testing that has been done. So basically what I did is I looked at records of patients who had come into our clinic, and these sometimes these were patients that were following with us, sometimes these are patients who had come for a one-time consult. And then I looked through their history and basically looked at had they had testing done. And then, as you'll see later, what psychiatric diagnosis were there and what had been tried to help treat those. I will say right off the bat that not everyone had this testing done. And so what I can tell you is I could tell you some differences in patients with deletions of less than 1,000 base pairs and missense mutations. There were not our patients with larger deletions did not have IQ testing that I could access. I can hypothesize as to why that might be, but that's kind of beyond the scope. So here's the big point of that. So first of all, patients who had deletions did score lower on their testing than patients with sequence variants. And it's quite a large difference. And what I really wanted to do was if those of you who have seen the results of, for example, IEP testing or that sort of thing know that IQ is just one big number, but there are other things that comprise it. There's, so for example, on the Wechsler Intelligence Scale for Children, the WISC, you may know that as there's verbal comprehension, visual, spatial reasoning, fluid reasoning, working memory, and processing speed. What I really wanted to do was kind of look at those individual subdomains and compare them. Unfortunately, it's impossible for me to do statistics on that because it wasn't all just the WISC. There were some people who had the WASI 4, the WACE 4, the Stanford Binet scales, and they have slightly different measures. So I can't actually compare them side by side. What I will tell you, though, is that just kind of putting them side by side and looking at kind of roughly analogous domains is that there did seem to be a relative strength of verbal ability and fluid reasoning. And I actually think that matters because so I've read in developmental medicine, I read through a lot of IEPs and make suggestions of how to change schooling and learning and that sort of thing. And there are patients of mine who have what is considered a nonverbal learning disorder, basically where, and these kids often struggle because they are able, their is relatively good, but they struggle a lot more with things like visual spatial reasoning, but people don't often pick up on that. And what I tell those families is, hey, listen, the verbal ability to strength, use that, change that numerical problem into a word problem, like, and that sort of thing. Knowing that information can be helpful. And so I do think that, regardless of the group analysis, I think having your school do IEP testing, or when you're turning 18 and you're having questions of guardianship, having the neuropsychological testing done, and that can really help you sort of leverage strengths, and I think that's really important. So now getting into the mental health concerns. So you'll notice that autism is missing from here. So that was already covered in Zoe Frazier's paper. So I focused on other symptoms. And so here's just a broad overview. And you see there's quite a lot of them. The most common ones were ADHD symptoms, anxiety symptoms, aggression, irritability, and sleep, although there were some other things that happened not infrequently as well, such as depression and regression. And so going into a bit more detail. So first of all, there's been talk of this already. There will be more talk of this. In the patients we saw who did have regression, this is concordant with the literature we know of. It happened in puberty and often described as having sleep disturbance as the first few symptoms. I'm very interested in learning more about this. And this is partly why I'm going to KKI to do more psychiatry, is because I want to see more patients who this is affecting and try and understand it at a deeper level, because it's such a hard thing. But I also did compare between groups as to what conditions are more or less prevalent. And interestingly, most of them, there was no difference. The two that did have a difference were anxious and ADHD symptoms. And actually, it was the patients who had the sequence variants, the mutations, who had more anxiety and ADHD compared to patients with deletions. So one could speculate, okay, well, maybe increased IQ, more awareness, more ability to be distracted or anxious. Maybe I also think that we as a medical community are bad at recognizing anxiety and ADHD in patients who are not able to tell us they are feeling distracted and anxious. So take that with a grain of salt. That's my little caveat there. So I just said that, but we could skip this slide. One thing that I think might be worth thinking about. So one of the other contexts I worked with Zoe in was actually our tuberous sclerosis clinic. And one thing that community has done is they put together this, because now we know a certain characteristic set of psychiatric conditions that happen with tuberous sclerosis. And so now there's what's called the TAND questionnaire, tuberous sclerosis associated neuropsychiatric disorder. And basically that's something where yearly you go through it with your clinician, you go through symptoms, and it's because a lot of times your doctor is going to be thinking about the seizures or the heart problems. And even though the mental health is really important and really impactful, sometimes it falls off the radar, understandably. So I would love to see something like that in practice. And so now getting into the treatments that have been used. So this is a kind of a busy table, but in this one, I just go through the different types of symptoms, how many of those patients actually received pharmacologic treatment, and of those patients, how many have had at least some efficacy, good or moderate efficacy from it. And the numbers are a little all over the place. ADHD is the most readily treated, which is not surprising in all of psychiatry. That's kind of the case as well. Aggression, anxiety, OCD symptoms tend to be kind of middling. And then once we get into other things, it tends to be a little bit lower on average. I will say sleep disturbance, pretty low percentage, which is somewhat disappointing. But I thought to make it a little more like personally relevant, I would go through the different classes of medications and kind of, this is a little bit arbitrary, but I sort of split them into groups of medications that had really no signs of response. Groups that had between like 1.25 of the patients have some good response, and then where more than 1/4 of the patients had a good response. I wish I could move those numbers higher, but this is what we're working with at the moment. And so I'll go through each of them briefly. I tend to default towards the generic names, but I'll also try and say the brand names when I can. So clonidine, Capthay, not really super effective. Guanfacine or 10x or Intuniv tends to be a little more effective, although not super. The antidepressants, I thought this was notable. A lot of them are not super effective. Sertraline or Zoloft actually tends to be a little more effective, which is interesting because, fluoxetine is our oldest and one of our most effective SSRIs, but not super effective in this case. The antipsychotics, a lot of these are prescribed, and you may have heard about olanzapine being looked, or Zyprexa being looked into as something that may help with regression, aggression, that sort of thing. And our data follows that as well. Although I will say quetiapine or Seroquel and ziprasidone or Geodon also show some promise as well. What show less promise is Abilify and Risperdal. And I'll tell you, just in my practice, most psychiatrists or neurologists, if they have to prescribe psychiatric medications, are going to reach for these first, because that is what's been approved by the FDA for treatment of aggression and autism. So I'll go through a couple more. I'll just put this up in case you want to look at it. Again, this is fairly preliminary, and I do have more, like 20-something more patient data to look through. So these numbers may change, but a couple of brief things I'll point out. Not a great pattern with stimulants. With the mood stabilizing medications, topiramate actually has a good response, but not for mood, actually for binge eating, because topiramate is appetite suppressing. And I will point out there is one patient who got carbidopa levodopa for motor symptoms and ended up having some cognitive improvements. Unfortunately, that patient then developed mania and had to be taken off of it. It's something to think about. So it's difficult to interpret definitively, but there are some medications that I think are more promising than others. I'm happy to talk about it after. I'll pause a little bit because I see a lot of cameras. I'll be right there. And then I'll skip that. So I think that's where we are right now. I have theories as to why certain ones are, which I'm not going to get into now, but I'm happy to talk about them after the fact. I want to thank Sid Srivastava, Zoe Frazier, who I've mentioned many times, Shauna Yu, resident at Boston Children's, and Tamar Katz. I literally can't find her picture anywhere. So thank you. Questions?
Eric, real quick. Sorry. All these slides are going to be available, so I know everyone was rushing to get Raj's slides. I saw a number of cameras going up as well, and these are going to be available after the conference. But I did just want to that slide of all the different medications. Just again, it refers back to everything that we've kind of been talking about with the different communication in the community. And I noticed this a similar slide, or maybe this slide was shown yesterday. And what is a little bit discouraging is the amount of overloaded medicines on the right-hand side that have a lower than 25% right, effectiveness. And so that's where we are. But I think it also highlights where and why we're investing in companies like Unravel and to discover this and figure out, okay, with these different subgroups, which are the ones that our community is going to respond to. And ultimately, that's what we're doing. Right now, we're band-aiding life to a degree, right? And so now we're going to get more targeted more and more with the research efforts. So thank you. This was a great presentation.